Now that you are quite familiar with how NSAIDs work, let me help you decide which drug is to be preferred in which condition. Well, it depends upon the cause and nature of pain, whether it is mild, moderate, or severe, whether it is acute or chronic, and is it accompanied with inflammation or not. Well, patient factors are also quite important in the selection of NSAIDs. Like, what is the age of patient? If he has any comorbidity. Is he using any other medication? Or if he has a history of allergy. Also to be considered are the past experience of the patient, acceptability, and individual preference. Though patients differ in their analgesic response to different NSAIDs. However, let me share with you some important guidelines about the choice of drug. Firstly, if a patient has mild to moderate pain with little inflammation, paracetamol or low-dose ibuprofen is used. For any postoperative or similar acute but short-lasting pain, ketorolac or a propionic acid derivative, diclofenac or nimesulide are used. If the patient presents with acute musculoskeletal, osteoarthritic, injury-associated pain, a paracetamol or a propionic acid derivative or diclofenac can be given. While exacerbation of rheumatoid arthritis, acute gout or acute rheumatic fever, or ankylosing spondylitis, which is a type of arthritis that causes lower back pain, requires naproxen, piroxicam, indomethacin, or a high-dose aspirin. If there is gastric intolerance to traditional NSAIDs, or predisposed patients, we can say, are treated with a selective COX-2 inhibitor or paracetamol. Arthritis patients who are dependent on NSAIDs and have developed peptic ulcer must receive concurrent proton pump inhibitor as gastroprotective agents because NSAIDs may cause gastrointestinal bleeding. Now comes the patients with history of asthma or anaphylactoid reaction to aspirin or other NSAIDs. Well, for such patients, nimesulide is preferred. In patients with hypertension or other risk factor for heart attack or stroke, need to avoid selective COX-2 inhibitor, but a propionic acid derivative or aspirin may be used at the lowest dose for the shortest period. Now, what the guidelines recommend for pediatrics is that only paracetamol, aspirin, ibuprofen, and naproxen should be preferred in them. Though aspirin is approved for the use in patients older than 3 years of age, but it should be used with caution in children due to the risk of Ray's syndrome. While for elderly patients, use lower dose of the chosen NSAID. Now, if we talk about the NSAIDs on the basis of formulations, fast-acting drug formulation is suitable for fever, headache, and other short-lasting pain, while longer-acting drugs or sustained-release formulations are appropriate for chronic arthritic pain. In pregnancy, paracetamol is the safest among analgesics, while low-dose aspirin is probably the second best. Hypertensive, diabetic, ischemic heart disease, epileptic, and other patients receiving long-term regular medication have possibility of drug interaction with NSAIDs. So this pointer should be considered carefully while prescribing NSAIDs to such patients. Now, let's quickly discuss these drugs, one by one. Reminding you again here that you can find the detailed lectures on acetaminophen or paracetamol and aspirin as well on sqadia.com. Let's talk about ibuprofen here. As it is the non-selective reversible inhibitor of COX-1 and COX-2, its analgesic, antipyretic, and anti-inflammatory efficacy is rated somewhat lower than high dose of aspirin. Remember, not to prescribe an ibuprofen to a pregnant woman or a patient with peptic ulcer disease. If I mention about the pharmacokinetics here, about all propionic acid derivatives enter brain, synovial fluid, and cross placenta. They are largely metabolized in liver by hydroxylation and glucuronide conjugation and excreted in urine, as well as bile. Now, naproxen is another propionic acid derivative and has similar mechanism as ibuprofen. Its anti-inflammatory activity is stronger, and it is particularly potent in inhibiting leukocyte migration that may be more valuable in acute gout. Other than this, it is also recommended for rheumatoid arthritis and ankylosing spondylitis because of its longer half-life. Well, its regular use can effectively suppress platelet function. Next we have diclofenac sodium, an analgesic antipyretic and anti-inflammatory drug. Diclofenac has similar efficacy to naproxen, and like other NSAIDs, it inhibits prostaglandin synthesis, but it's somewhat COX-2 selective. And if you remember, I mentioned earlier that antiplatelet action of NSAIDs is due to COX-1, so antiplatelet action of diclofenac is not appreciable due to sparing of COX-1. So it also does not block the cardioprotective effect of low-dose aspirin. Next, Non-Steroidal is an NSAID that is a relatively weak inhibitor of prostaglandin synthesis and preferential COX-2 selective. The analgesic, antipyretic, and anti-inflammatory activity of Non-Steroidal has been rated comparable to other NSAIDs. It has been used primarily for short-lasting painful inflammatory conditions like sports injuries, sinusitis, and other ear, nose, throat disorders, dental surgery, bursitis, that is the inflammation of bursa, low backache, dysmenorrhea, postoperative pain, osteoarthritis, and for fever. Next one is ketorolac, which is oral acetic acid NSAID that has potent analgesic but modest anti-inflammatory activity. In postoperative pain, it has equaled the efficacy of morphine, but does not interact with opioid receptors and is free of opioid side effects. Like other NSAIDs, it inhibits prostaglandin synthesis and relieves pain primarily by a peripheral mechanism. Now we have indomethacin, which is an indoleacetic acid derivative and is a potent anti-inflammatory drug with prompt antipyretic action. While it relieves only inflammatory or tissue injury-related pain, it is thought to be a highly potent inhibitor of prostaglandin synthesis and it suppresses neutrophil motility. Now, moving towards piroxicam, which is a long-acting potent NSAID with anti-inflammatory potency similar to indomethacin and good analgesic antipyretic action. It is a non-selective, reversible inhibitor of COX, thus lowers prostaglandin's concentration in synovial fluid and inhibits platelet aggregation and prolongs the bleeding time. Lastly, we have celecoxib now. The COX-2 selectivity of celecoxib is modest and similar to that of diclofenac, and it exerts anti-inflammatory, analgesic, and antipyretic actions with low ulcerogenic potential. So now that you're quite familiar with some commonly used NSAIDs, let's have a look at the other side of the picture.